Hello, everyone, and welcome back to this year's CR Arthritis event at the Canadian Rheumatology Association and Arthritis Health Profession Association's annual meeting in Winnipeg. I'm Kelly Lenvoy, VP of Communications and Public Affairs at Arthritis Consumer Experts, and I'm joined today by somebody who's familiar to probably a lot of members of our audience. It's Ms. Ellen Wang. Ellen, hello.
Hello, Kelly. It's so great to be here.
Great for you to join us today. As a reminder to our audience, you're not only programs coordinator here at ACE, Ellen, but you're also a PhD student and an Arthritis Research Canada trainee working under the supervision of our friend, Dr. Linda Lee. And you're currently in some intense studies to become a physical therapist at UBC. How's that going?
It's going really, really well, Kelly. It's a pleasure to be back in school. I've always loved school and getting to do the hands-on part of it. There's really nothing nothing better to see yourself in those roles and be practicing those skills.
I agree. Well, great that you could join us. And it's also very opportunistic because today ACE's poster was presented at the annual meeting. And that poster was on health literacy in arthritis care in Canada, the perspectives of BIPOC individuals across age categories. And Ellen, you wear many hats. You were the lead author on that, as well as many other members of the ACE team and some researchers from Arthritis Research Canada. And congratulations on the poster presentation. And we're going to talk about that presentation today. And maybe to start, just so our audience is familiar, when we talk about health literacy, what we're talking about is the ability to access, understand, evaluate, and communicate health information to promote and maintain one's own health and health outcomes. And what we know from the evidence is that if we have limited or deficient health literacy, that's a real barrier to accessing health services and care. It could lead to a worsening of a chronic disease, and it could also result in ineffective use of health services. So when we look at our survey, Ellen, and we tease out some of these findings from the poster, we took a deep look at responses from BIPOC, Black, Indigenous, and people of color, versus non-BIPOC or white respondents. Where did we start seeing some of these glaring disparities between the two patient populations?
You know, Kelly, when we did our analysis, we had 1,148 respondents to complete the survey, and we had about 449 that were BIPOC, so it's about 40%. So you can think like 2/5, and we had 699, so about 61% were white respondents. So we had a pretty good split between BIPOC and white respondents. And across the respondents, if you just simply looked at BIPOC respondents versus white respondents, the differences were actually pretty small. So they were relatively comparable for most things. And then, once we get down to interactions with healthcare providers and ability to self-manage, we started to see some differences. But really, the most striking or the most prominent disparities, we could say, were between individuals who were not only BIPOC, but individuals who were BIPOC and over the age of 54. And 54, this number, again, we had done our analysis, we had designed our questionnaire to go by decades, right? And 54 was simply the decade that we had looked at where, oh, that is very interesting. In individuals born before a certain year, meaning that they were greater than 54 years of age, had really big differences. So individuals who were BIPOC over the age of 54 years had a really big differences in communication with health providers, understanding information online, in media, and applying that health information when compared to white respondents greater than 54 years of age, and also when compared to BIPOC respondents who were younger than 54 years of age. So not only were they different between white respondents in the same age category, but they're also different between BIPOC individuals who are younger and then BIPOC individuals over the age of 54. So you could see when we did our analysis, not only, again, that difference was large, but the difference was large when you compared it multiple ways.
That's interesting because these are older adults who are still in the workforce, generally speaking. We're not talking about, people who are retired and end of life, but still very much in the prime of life, peak wage earning period, responsible for, largely for family income and support. So very critical for these people to maintain their health and not experience any challenges as it would relate to their work or employment and productivity. So kind of a critical time period that you've identified there. So when we look at, so we mentioned interaction with healthcare providers. What are some of these disparities that we found?
So for example, when speaking with healthcare providers, again, they felt individuals who are BIPOC and over the age of 54 had more difficulty communicating with healthcare providers, and they felt less encouraged, or they reported less encouragement from healthcare providers when compared to white respondents over the age of 54, and also when compared to BIPOC respondents who are younger. So not only was it when we did the analysis by age group, but also in this case by ethnicity, right? So we saw, and those aren't small differences. It was like differences of, for example, 4 times, right? It was the difference between, 5% of BIPOC respondents over the age of 54 reporting, I felt encouraged, I felt supported, versus 25, 30% of white respondents or BIPOC who are younger.
Was there anything that stood out in terms of where they were finding that information? So I'm just thinking of that difference that you've cited between this over 54 segment compared to a younger BIPOC segment. And I'm thinking maybe uh, the accessibility of online medical information. Would that be maybe one reason? But when it came to sourcing or finding information, what did we find out about this particular group?
And that's exactly right, Kelly. When we, spoke, or we touched on this already, but finding information online between BIPOC respondents over the age of 54 years and under the age or younger, 53 years, we saw, for example, 10% in BIPOC respondents over the age of 54 reporting they knew where to find information online, versus 40% of BIPOC younger than the age of 53 who are like, I know where to go to find information online, right? That's it's a 4 times difference. And then in media, so in other media, whether that's, we're going to the newspaper or hearing things on the radio, 14% in individuals or BIPOC individuals over the age of 54 versus in 33%. So it's a 2 times difference in this case in BIPOC younger than 53 years of age. So these are differences not of a few percentage points, but of folds, right? Multiple times the difference.
So another area of questioning that we included in the national survey, because it is so important, is as it relates to health literacy, is about using the information to make better health decisions. And we know it's important because if people understand, it helps people, I think, better understand their health challenges It might help them choosing the best, most appropriate treatment. It might help guide them in terms of what exercises to do and how to do them correctly, what are suitable to them. And then finally making healthy food, diet, and nutrition choices. In that area of investigation, what were some of the findings?
So Kelly, we had actually broken this down to look at not only medications, but we looked at exercise and nutrition. So we kind of broke it up, our line of questioning, into three kind of components. And we asked about, number one, do you know how to take medications? Do you know how to exercise? So we asked about the knowledge piece. And then we had a follow-up question in each of those domains of medications, exercise, as well as diet. How confident are you that you can do it, right? So we try to capture the knowledge piece of health literacy and also the apply piece of
Mhm.
health literacy. And what we saw was, for example, when it came to medication instructions, only 22% of BIPOC over the age of 54, so these are individuals who are, like you said, perhaps in the prime of their career, less than a quarter of them understood or fully understood medication instructions versus 74. So this is 3 times, right, of white respondents over the age of 54 who reported, we fully understand our medications. We know when to take them. We know how to take them, right? So this is truly like a 3 times difference. And then this trend was continued for questions related to exercise. So number one, do you know how to exercise? And number two, are you confident that you can exercise? These very, again, large differences, large discrepancies, large disparities were seen across exercise and nutrition. So we can see there's a deficit in not only the knowledge piece, but an even greater deficit in the apply piece, applying information.
So another huge gap here we're talking about is limited health literacy and how it's impacting on a person's ability to practice self-care. I think essentially what we're saying. Um, is there anything else around this area of self-care that we identified?
Yeah, we had a few questions kind of close to the end of the survey asking, individuals about how they would want to improve their health literacy. Would
Hmm.
it be support meetings? Would it be one-on-ones? Would it be, better online resources? And interestingly, this is across all age categories. BIPOC individuals, approximately half of them had said they would like more group related activities, so like support meetings. So you could see that there was this need to not only learn, but learn in a group setting with peers. There's
Hmm.
less want and less need for the one-on-ones or more time with doctors, for example. There's more of
Hmm.
this, I want a cohesive, I want a holistic, I want to be supported, I want to be with others who have my disease, especially from BIPOC. And this was across all age categories. And this was not only true for the 54, over 54 that we were talking about. So I found this super interesting. And the last piece is when we looked at BIPOC respondents versus white respondents, we found that they were less likely to ask others for help, about half as likely. Half as likely. So about 20% of BIPOC respondents, is across age categories, were comfortable asking others for help when compared to about 40% of white respondents. So it's interesting that there's a need and a want for group-related learning, but there's a barrier in going out and reaching out to
Hmm.
people, to ask questions, to discuss, to share vulnerabilities. So I found that like really interesting, a very perhaps a fruitful direction of research, because not only is there a need and a want for these modalities and these treatments and these support groups, but there's also these really interesting, seems to be more specific to BIPOC barriers that exist. And no, not a complete paradox, but I just found that really, really interesting and something for us to kind of, sit with as researchers and as advocates.
That's a nice stepping stone to my next question, and that is finally uh, in Winnipeg at the meeting, what recommendations and conclusions did you share with people coming from the paper? What you've just described to me is obviously opening up this box about being able to develop systems and programs and methods to deliver culturally sensitive and appropriate care to people with arthritis or any other chronic disease. What were some of these conclusions or recommendations that you delivered in Winnipeg?
Kelly, if I put on my aspiring clinician hat, we always talk about tailored therapies, right? Whether that's with these rheumatologists or personal trainers or physiotherapists. We put on that hat and we understand that the person walking into the room is different from the next person that walks in the room or the person who was in our office before. But when we approach education, we produce it for the masses. And yes, we've done better with lay summaries, we've done better with visuals, we've done better with auditory, learning, but I don't think there's adequate emphasis or resources being allotted to the education piece around the apply, right? I think patients know what to do. But why is it that the apply piece is so difficult, or that's where we see the largest discrepancies? So yes, we can produce, handouts, printouts of medication and instructions in different languages, but then we don't talk about, what is culturally appropriate in terms of helping someone apply, taking medications, right? Maybe the cues are different. Instead of taking it at every, meal or in the morning, take it when, you pray in the morning, you pray in the evening. So how do we even make those cues or that apply piece tailored to that individual or that group? So thinking of it really as a puzzle that needs individualized attention and focus. And again, this may be like a cross-discipline project that we pursue in future, but just starting to think about health literacy and its multiple different pieces, right? So the find, the understand, the apply, and then can we make each of those pieces tailored to whoever is sitting in front of us or a group of individuals that may need those resources and may benefit from those resources. So really thinking about the tailored piece.
Fantastic. You've heard me say this before that, I have a great deal of faith and hope in the next generation of arthritis leaders like yourself, Ellen, and look forward to talking to you about solutions to these really deep, probing questions that are going to improve the lives of people across Canada. So keep up the good work. Good luck with your studies. And thanks for joining us.
Thank you for having me, Kelly. It is always a pleasure.
Thanks to you, everyone in our audience, for joining us for another episode of See Arthritis. We're approaching the final day of the meeting, and we look forward to presenting highlights from that final day with you. See you again soon. Bye-bye.